Right, let's just dive straight into this. Welcome to this Focus Clinical Explainer. Today we're unpacking something that honestly frustrates clinicians and patients alike: persistent postural perceptual dizziness, or PPPD. We're going to completely demystify the diagnostic criteria and the actual mechanisms driving this complex condition. We'll look at the definitive Bárány Society guidelines and give you the precise frameworks you need to evaluate these cases effectively.
Now, this explainer is based on the literature review, Persistent Postural Perceptual Dizziness, Rehabilitation, Triple Track Therapy, VRT, CBT, and Pharmacotherapy, published by Australian Dizziness Clinics. You can find the full paper at australiandizzinessclinics.com.
So let's start with a question that really gets to the core of this whole clinical mystery. Why on earth do patients with perfectly normal vestibular tests stay disabled for years? I mean, if you manage dizzy patients, you know exactly what I'm talking about. You've got someone sitting right there in your clinic, genuinely suffering, life totally upended. Yet every single peripheral and central vestibular test you run comes back completely clear. It's incredibly frustrating for them, and let's be real, it's pretty perplexing for us as clinicians too.
Well, the key to unlocking this is understanding that the precipitating event resolved, but the perpetuating factors did not. This right here is the major paradigm shift we need to make. A patient might have had an acute vestibular illness, maybe BPVP, or even a severe panic attack. That initial trigger, it's gone. But if your rehab is only targeting that old precipitant, you're missing the actual driver of the chronicity. They aren't dizzy because of the past injury, they're dizzy because of what their brain is actively doing right now.
Section 1. The Bárány Society 2017 criteria, or the 4 keys to diagnosis.
So here are the 4 specific criteria you need to tick off. First up, the patient has to experience dizziness or unsteadiness on more than 50% of their days for at least 3 months. Second, the symptom pattern has to be persistent rather than episodic. Third, and this one is super characteristic, their symptoms are exacerbated by upright posture, active or passive head motion, or complex visual stimuli, like scrolling on a phone or walking down a busy supermarket aisle. And fourth, there's got to be a precipitating event in their history, like an acute vestibular insult, a mild TBI, or an anxiety attack. And crucially, their vestibular testing is typically completely normal. Their peripheral and central functions are totally fine. These symptoms are very real and deeply disabling, but they are definitely not coming from a broken inner ear.
This flow really brilliantly illustrates how we apply those exact criteria in the real world. Start at the top. You've got a patient presenting with persistent dizziness. Now, if their vestibular tests are abnormal, you head down the left path to look for structural causes. But if those tests are perfectly normal, you move to the right. From there, if the symptoms are persistent and triggered by posture or visuals, following those criteria we just walked through, bam, that leads you straight to a PPPD diagnosis. It's a remarkably clean, logical pathway that completely takes the guesswork out of normal test results.
Moving on to Section 2, the mechanism. Let's explore the perceptual mismatch loop.
The fundamental driver here is what we call perceptual mismatch. But what does that actually mean? Well, it means the brain is still expecting the strong, distorted vestibular input it felt during that initial acute precipitating event. But the physical reality is that the input from the ear is actually completely normalized. It's like the brain is bracing for a massive storm, but the weather outside is perfectly calm.
And when this mismatch happens, it immediately throws the brain into threat detection mode. The brain's thinking, uh-oh, something is very wrong here, I need to protect myself. And that directly causes a heightened attention to the body, a massive over-reliance on visual cues, and intense postural rigidity. It basically becomes this self-sustaining cycle where the brain's false prediction actually creates the exact symptoms the patient is so terrified of. Let's break that loop down step by step so we can see exactly where the wheels fall off. Step 1, we have perfectly normal sensory input coming in from the vestibular system. Step 2, the brain stubbornly expects that old damaged signal, which creates a prediction mismatch. Step 3, this mismatch triggers a massive threat amplification. Step 4, because the patient suddenly feels threatened and unsteady, they start adopting avoidance behaviors and moving rigidly just to feel safe. And finally, step 5, this breeds hypervigilance. They're constantly scanning for any sign of dizziness, which just feeds right back into the brain, misinterpreting totally normal sensory input. So the persistent perceptual error fuels the avoidance, and the avoidance just locks the loop in place.
Which brings us to an absolutely massive clinical pearl straight from the literature review. Quote, communicate the mismatch model in plain language at session 1. Patients who understand why they feel dizzy despite normal tests engage with retraining.
patients who hear only that their tests are normal often disengage. I mean, that is profound. If you just look at a patient and say, hey, your tests are fine, what they hear is, it's all in your head. But if you take the time to explain the perceptual mismatch, if you give them the actual why, you validate their real symptoms, and you give them a logical biological reason to actually buy into the rehab.
All right, Section 3, the 3P model, and how it frames our treatment decisions.
The 3P model breaks this whole disorder down into 3 very distinct factors. First up, predisposing factors. These are things that increase the patient's baseline vulnerability. We're talking trait anxiety, a history of depression, or maybe prior vestibular events. Second, precipitating factors. These are the actual events that triggered the onset of the PPPD in the first place, like vestibular neuritis, a concussion, or a massive panic attack. And third, perpetuating factors. These are the things actively maintaining the disorder long after that initial trigger is totally gone. Things like visual dependence, somatic attention, and avoidance behavior.
And here is the core takeaway you absolutely need to remember. Rehabilitation primarily targets perpetuating factors. Why? Well, because those predisposing vulnerabilities and precipitating triggers are stuck in the past. You can't hop in a time machine and undo a vestibular neuritis, and you can't just erase someone's trait anxiety. But the perpetuating factors, the visual over-reliance, the hypervigilance, the stiff, rigid movement, those are highly modifiable. And because they're the exact things sustaining the disorder, they absolutely have to be the primary target of our treatment.
When we look at the 3 main tracks of therapy, vestibular rehabilitation therapy, cognitive behavioral therapy, and pharmacotherapy like SSRIs or SNRIs, the ultimate goal is super clear. A triple-track plan aimed right at breaking those perpetuating factors converges directly onto functional recovery. This kind of targeted multidisciplinary approach is exactly what drives the 70 to 80% substantial improvement rates we see in optimal PPD management.
In Part 2 of this Explainer series, we'll be running through the CBT-informed assessment battery, screening for engagement risk, and framing out that triple-track plan.
For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this Explainer series, head over to AustralianDizzinessClinics.com. Please don't forget to subscribe and leave a rating if you found this helpful. And before you see your next dizzy patient, ask yourself, are you still trying to fix their initial injury, or are you ready to start retraining the brain's prediction error?